Okay, we're back trying to do some more of these videos from my home office here so that we can try to keep up with the syllabus, with the daily schedule. So I'm going to go ahead and record this process of normal labor. This is what we should have covered after the exam Monday. So I'm going to go ahead and cover that today, and I'll ask if y'all have any questions Monday, March the 7th. We'll see if y'all have any questions, and then we'll move on with nursing care during labor. And at 9:30 on Monday, March the 7th, we will do the exam review. So we'll have to be back on the computer. So if you brought your laptop to take your exam, your first exam, please bring your laptop back with you. It has to be the same laptop for you to log into and be able to see which questions you missed, so that we can kind of do the exam review. Okay, process of normal labor. So labor is the process by which the fetus, placenta, and the amniotic membranes are expelled from the uterus. Onset of labor usually occurs due to a combination of things. Includes changes in maternal hormone, stretching of the uterus, and an interaction between the placenta and the fetal pituitary, hypothalamus, and adrenal glands. Okay, so it's a pretty complex process, as you already know. Factors that influence the process of labor are going to be maternal preparation. Is the mom ready? Has she attended any labor classes? Does she kind of know what to expect? Labor support. Does she have a support person? You know, some people have so many support people that we're having to kick them out. Others, it's just them, and they don't really have a support person, so you, the nurse, are their support person. Maternal positioning during labor and delivery. So positioning can have a significant impact on how well labor progresses. Okay, and we're going to talk about that as we go on. Another factor that influences the process is any procedures that are encountered by the mother during the labor process. So getting an epidural, that's going to influence the process of labor. It's a procedure that she gets during the labor process. All right, events prior to the onset of labor. Something that takes place before labor. There's actually 6 things we're going to talk about. So they're not numbered. I like to categorize things, and this one is not categorized, but so I'm just going to tell you what it is first, and then we're going to talk about each one specifically. So special events prior to the onset of labor include lightning, nesting, mucus plug, Braxton Hicks, cervical changes, and ruptured membranes. Okay, so starting with lightning. Lightning is when the presenting part settles into the maternal pelvis. Hopefully it's the head. So it occurs approximately 2 weeks prior to the onset of labor. The woman has a sense that the baby is dropped, and you'll hear people talk about that a lot. Oh, it looks like your baby's dropped. What the mom feels is she can feel that sometimes, and she'll also feel like she can breathe a lot easier because with this lightning, with this movement of the fetus down into the maternal pelvis, she has more room to breathe. So she breathes a lot easier. She can eat more at mealtime. There's less pressure up on her stomach. So there's less pressure on the upper anatomy, but more pressure down on the lower anatomy. So the bladder, there's a lot more pressure on the bladder. It feels like she has to pee every 5 seconds, especially if the baby's moving around and really active. All right, they may also experience leg cramps and edema or swelling of the lower legs related to the increased pressure on the blood vessels by the growing uterus. All right, then we've got nesting. So nesting is when you get this burst of energy experienced by the mom to prepare the home for the new baby. So usually these moms are cleaning everything, preparing many meals, preparing the nursery. They just have this huge burst of energy. Usually occurs 1 to 2 days prior to the onset of labor. The cause is unknown why this happens. But you need to be sure that you've warned the mom to conserve her energy for the work of labor. Sometimes women will get so caught up in this nesting. They do so many things, and obviously, as you can see here, it's very close to the onset of labor, that they have really worn themselves out before they even get to labor. Okay? Unfortunately, I never had nesting. I wished I'd had some nesting, but I've never really had that experience. mucus plug. So you'll lose your mucus plug. Mucus plug is a protective plug, so to speak, of mucus inside the cervix during pregnancy. So the loss of the mucus plug can occur 4 weeks to 1 day prior to the onset of labor. So usually what happens is as the cervix starts to open and relax a little bit, that's when you lose this mucus plug. And it can kind of look like a bloody show, just like a pinkish tinged mucousy vaginal discharge. All right, you'll have Braxton Hicks contractions, which are irregular, painless practice contractions. They're also referred to as false labor. They do not increase in intensity, duration, or frequency. All right, now we'll have our clinical signs here. So cervical changes, which was one of the things I listed. Cervical changes would be ripening, effacement, and dilatation. So ripening is a softening of the cervix. They just call it cervical ripening. Effacement is thinning of the cervix. It gets much thinner. And dilatation is actually opening of the cervix. All right, so ripening, I don't have anything more to say on that. That is what it is. It's just the softening. Effacement, though, is this thinning or shortening of the cervix. So it is recorded as a percentage. So your normal cervix is approximately 2 centimeters long when it's non-effaced. Okay, good. I'll show you in the next slide here. The cervix is completely effaced when it is as thin as a piece of paper. So it is super thin. So that's when you are called 100% effaced, and that's what they'll call it. So if you'll notice here before labor, this is nice and thick. This is your 2 centimeter normal non-effaced cervix. Then you've got your early effacement. Okay, now you lost your mucus plug here because it was here. You've probably lost your mucus plug now. Then we'll go down here into complete effacement. So now we're super, super thin and spread out a little. Okay, but we're still not dilated. This effacement is just the thinning of this tissue right here. Dilation is the actual widening of that tissue there. Okay, so you can have complete effacement before you have complete dilation. All right, so dilation is when the cervix actually opens to allow for passage of the fetus. All right, it's measured in centimeters. Complete dilation is 10 centimeters. Now your primipara usually experiences effacement before dilation. Your multipara or multip, effacement and dilatation often occur at the same time. So they'll often dilate 1 to 2 centimeters even before the onset of labor, which is very common. So when people who are multips and they'll go into, they're getting close to time for delivery and they'll go in and something may be going on, the physician may check their cervix and say, oh yeah, you're 1 to 2 centimeters dilated. Well, that's nothing new. I mean, they're probably walking around 1 to 2 centimeters dilated for months now. And that's no big deal. All right, so how are we going to know true labor versus false labor? So over on the left-hand side, these are your true labor symptoms or signs, and these on the right are your false labor, okay? So true labor, you're going to have progressive dilatation and effacement. If we have false labor, like the Braxton Hicks, we have no actual change in dilatation and effacement. So many times when I was pregnant with the twins, I was sent to the hospital multiple times for premature onset of labor. It's called POL, premature onset of labor. And one of the deciding factors on whether or not they were going to try to stop the labor or determined obviously by how many weeks pregnant you are, but is also how long have you been having these contractions, how long have you been in labor, and is your cervix actually changing? Are you dilating and effacing or not? So obviously many times I went in and there was no change, so everything, that was fine. That you're going to get concerned when you do have this progressive dilatation and effacement if you're preterm. Otherwise, this is a good thing. All right, true labor, you're going to have rupture of membranes. In false labor, your membranes remain intact. Remember, membranes, that's your amniotic fluid. Rupture of membranes is that amniotic sac that holds the amniotic fluid. You'll have this bloody show during true labor. Again, this is sometime more than likely your mucus plug, where you've lost your mucus plug. It's occurring because you're actually having some dilatation and effacement, and that's why you're getting that bloody show. You'll have regular contraction pattern, becomes longer, stronger, and closer together. If you're in true labor, your pain intensifies and radiates to the backs and thighs. If you're in false labor, the pain is uncomfortable, but it doesn't intensify, and the pain is usually confined just to the abdomen. When you're in false labor, also activity or position changes can often decrease the frequency or stop the contractions. But if you are in true labor, contractions continue and get stronger with position and activity changes. Okay, so those are really good things to know as far as when we're in true labor versus false labor. So be sure you understand these concepts. All right, rupture membranes. I think we've talked about this before. We have SROM and AROM. So SROM is spontaneous rupture of membranes. This is considered the actual onset of labor. Okay? If contractions and cervical change do not occur with the onset of the rupture of membranes in a term patient, labor may be induced due to the risk of infection to the mom and baby. If they are membranes have been ruptured and we now have this open path into the baby, obviously, and much greater risk for infection, so they will oftentimes go ahead and induce labor to get things rolling when we've ruptured, if we're pretty close to time for delivery. Now, some people will have spontaneous rupture membranes and they call it PPROM, premature spontaneous rupture membranes, and these people will oftentimes remain in the hospital. They'll be on antibiotics long term, trying to prevent infection and keep the baby in utero a little bit longer so that the baby can transition well once they're born. All right, it can be a trickle or a gush of fluid depending on how high or low of a leak it is. Sometimes people come in, they think they've ruptured and they've just peed on themselves. Very common. But other times people think, oh, I have to have this big gush of fluid, so they don't come in, they don't come in, they don't come in. Well, they've ruptured several days ago, and I just have had this little trickle of fluid. Right, then we've also got this artificial rupture of membranes, so the AROM, which is when the practitioner will use the amni hook, which I know we've talked about this before. So we'll use this amni hook, it's like a little crochet hook, to put this small hole in the amniotic sac to stimulate the maternal hormones and augment labor. So oftentimes, if mom is kind of progressing through labor, but it's a little bit slower than anticipated, we need to start kind of moving the process along. The baby is showing signs that we need to get things going here. They will go ahead and do this amni hook, and they'll go ahead and just hook the bag of water, break it, rupture her membranes, and the rupturing of the membranes stimulates the maternal hormones to go ahead and augment labor. All right, we talked about all the things that are going to happen before labor. Now we're going into labor. So there's the 4 P's of labor: pelvis, the size and shape of the pelvis; the passenger, which is the fetus; powers, which is the effectiveness of contractions; and psyche, the preparation for labor and delivery of the mother, and can also be previous labor experiences of the mother. Excuse me. So number 1 there in the 4 P's was pelvis. So this is the passageway. The bony pelvis forms the rigid passageway in which the fetus is delivered vaginally. The shape and dimensions of the woman's pelvis indicates whether or not she will be able to have a vaginal birth. Sometimes they can just tell based on doing a vaginal exam if the woman's pelvis is going to be too small to begin with. They won't even attempt a vaginal birth. Sometimes they will judge based on ultrasound on how big they think the baby is and how big her pelvis is, and determine whether or not they think she can have a vaginal birth. So the cervix and the vaginal canal are also part of the passageway that are made up of soft tissues. So it consists of the pelvis, cervix, and vaginal canal are all parts of the pathway. This is your pelvic inlet. So this is looking from the pelvis from the top down, cross-sectional view. AP is your anterior posterior diameter, and trans is your transverse diameter. These little bony prominences right here are important. All right. You've got your prominence of the ischial spines right there. And then here's your pelvic outlet. So this is looking from the bottom up, basically. The pelvic outlet. This is the spine back here. All right, pelvic shape. It's the shape of the pelvic inlet that determines the pelvic type. So we just discussed we have a pelvic inlet and pelvic outlet, but it's the shape of the pelvic inlet that determines the pelvic type. So there are 4 types of pelvis: gynecoid, anthropoid, android, and platypeloid pelvis. Now, your gynecoid is the optimal, the most common really, and the most optimal for vaginal birth. Then you've got anthropoid, which is not uncommon either. Android is your heart-shaped pelvis, and your platypeloid is a flat pelvis. All right, so here's your gynecoid, is your typical female pelvis. At least half of all women have a gynecoid pelvis. The round shape allows for the infant to negotiate the dimensions of the bony pelvis. See how it's nice and round for the fetal head. Then you've got your anthropoid, where the dimensions are very elongated. Here, very elongated instead of circular. Your android is your typical male-shaped pelvis. It's the heart-shaped pelvis. This is your male-shaped pelvis. And your platypeloid, pelvis, which is your least common type of pelvis, and it's very flat. Okay, so here's another picture. Here's your female pelvis on top, your male pelvis on the bottom here. Notice how wide this pubic arch is versus the male pubic arch. All right. Got your pelvic brim here on the female pelvis. All right, now we'll move on to number 2 in our 4 P's of labor. So number 2 is the passenger, refers to the fetus. We've got several areas we need to look at with the fetus: the fetal skull, fetal attitude, fetal presentation, fetal position, and fetal station. All affect the progress of labor. Now, your fetal skull is the most important fetal structure in relation to labor and birth. The diameter of the skull must be small enough to allow the head to travel through the bony pelvis. The cartilage between the bones of the fetal skull allow for overlapping during labor, which allows for reduction in this fetal head. And what you'll get is molding or elongating of the fetal head, allowing for accommodation through the birth canal. Now, this is more pronounced in primates, primipares, first-time deliveries, first babies. This molding and elongation is more prominent. And but what happens is the sutures of the skull will overlap so that the fetus can be delivered, and then they will gradually come back. All right, so here's your sutures, your birth canal. So this is the back of the baby's head. This would be posterior, baby's face. So this is anterior. This is bone. This wide part in the middle is what they call the fontanelle, but this big one right here, this diamond shape, is your anterior fontanelle. Then you have your sagittal suture that runs to your little triangle shaped in the back, which is the posterior fontanelle. All right, then we've got fetal attitude, which is still part of passenger, the second P. Most common and more favorable for vaginal birth is flexion. The fetal attitude you want is flexion. Flexion presents the smallest diameter of the fetal skull to the bony pelvis, so it's approximately 9.5 centimeter presenting size. So the fetal attitude changes, particularly extension of the head, which causes the fetus to present a larger diameter of the fetal head to the maternal pelvis, making vaginal birth difficult and sometimes impossible. So these are your different positions here that we can have this fetal head during birth. Obviously, this seems much more smooth for delivery than the others here. So here we have in fetal attitude, this is your well-flexed attitude, your vertex presentation. So flexed attitude, baby's chin to chest. The smallest part is presenting first through the pelvis. Then we've got no flexion or extension. This is called military presentation, or occipitofrontal diameter presents. It's 11 centimeters. All right, you've got your partial extension, which is called a brow presentation. So you notice the baby's head is flexed or extended. but not fully extended, so your brow is presenting first. This is about 13.5 centimeters. Then if you've got full extension face presentation, this diameter is also 9.5 centimeters, but causes a lot of facial bruising. All right. Fetal presentation is determined by the body part of the fetus that is the lowest in the maternal pelvis. So there's 3 ways that a fetus can present itself. We've got cephalic, which is head first, 96% of babies. Breech, which is going to be feet or buttocks first, it's 3%. And then you've got transverse or shoulder presentations. All right, vertex. This is what everybody wants. This is what should happen. This is what we hope happens. A nice vertex presentation. Your head is down. Everything's wrapped in. Baby's butt up here. Remember how we would know what we've got here as far as fetal presentation is by doing that Leopold's maneuver. Okay. Then we've got breech presentation. Now this right here in the uterus we've got showing here is a footling breech. So we've got feet first. This is not good, but it happens. So we can have a footling breech. We can have an incomplete breech. Or I mean, this is complete breech where it's just the buttocks are presenting first. We can have an incomplete breech where we've got the baby's legs are not crossed. They've got one straight up and one kind of crossed down. And then you've got a frank breech where the legs are literally straight up. This is very interesting to have babies born like this, usually born via C-section, unless they're super tiny babies. They're going to be born via C-section. But it takes it's not like those feet come straight down. I mean, they've been in utero for 9 months, flexed up like that. It can sometimes require some physical therapy even to get those muscles relaxed enough for the hips to let those legs kind of come down. It's real interesting. And then you've got your shoulder or transverse presentation. So this fetus is in the transverse position. They're straight across. Okay. So when I was pregnant with the twins, I had one was breech, complete breech, I think. And the other was transverse. There was no way they were coming out vaginally. All right. Fetal position determined by comparing the relationship of the presenting part to the quadrants of the maternal pelvis. So the nurse has to first establish the presenting part and then the appropriate point of reference. So if the fetus is vertex or cephalic, the fetal position is referenced by the position of the occipital aspect of the fetal head. All right. The nurse must next determine the side of the maternal pelvis that the presenting part is facing. So if the occipital side of the fetus is facing the mom's right side, or if the occiput is facing the left side. Lastly, the nurse designates whether the occiput is facing the anterior or the posterior portion of the pelvis, or if it's transverse. So I know that's, well, I find that incredibly confusing. So we're going to break it down a little bit further here. So if the fetus facing mom's back, if the fetus is facing mom's back, he or she is in an anterior position. So the occiput is to the anterior pelvis. Back of the head is to the front of the anterior front of the pelvis. If the fetus is facing the mom's front, then he or she is in the posterior position. So the occiput is to the posterior pelvis. If the fetus is facing one side or the other of the mom, he or she is in occipital right or left transverse position, depending on which way he or she is facing. So this breaks it down a little bit better for you. This is occiput posterior. This is LOA, left occiput posterior, right occiput posterior, right occiput transverse, left occiput anterior, and right occiput anterior. So if you guys have questions on this, please ask me. I expect to have some questions on this type of thing. This is really confusing. The next slide explains a little bit better too as far as positioning for you. But I want you to be sure that you know these positions, okay? And these ROP, ROA, that kind of thing. What's presenting, what are we doing? All right, so LOA is the most common, and then ROA is probably shortly after that. But this describes it a little bit better. Now you'll see the big picture, and then the little picture is if you were looking if you were doing a vaginal exam on the mom and you were looking into the cervix, this is what you would see. Okay. OP, if you have OP, occiput posterior, whether it's ROP, or LOP, it doesn't matter. That's what they call sunny side up. This is called your sunny side up baby. Face comes out or face up. So they come out, their skull is on the mom's tailbone, pushing on the mom's tailbone. It causes a lot of back pain and a lot of back labor. It's very uncomfortable for the mom. So if you got posterior positioning, the fetus is facing outward towards the mom's abdomen. The occiput, which is the hardest part of the baby's head, is pushing against the mom's lower back and sacrum. So it does cause a lot of back pain. Unfortunately, this is what I have with my daughter. Lots of back labor, lots of back pain, and she came out sunny side up. No wonder I was hurting so bad. So labor is often prolonged due to the different diameter of the head fitting through the maternal pelvis. Things are just not going the way they're supposed to. It's not bad. It's just not the way it was planned. So the baby may have some bruising on the forehead where the softer part of the head has been pushed against the mom's bony pelvis there. All right, so here's a picture of your anterior versus posterior, the facing backward head first. So this is your normal position and presentation. So you should come out this way where your face, the baby's face is kind of going down the mom's spine. And then you've got facing forward. This is your abnormal position. This is your OP. Occiput is the back of the head. Occiput posterior, OP. Sunny side up. They're coming out face up. Okay. So please, please, please ask me questions if you have questions about this. This can be an extremely confusing concept. It's taken me a long time to get it straight in my head about what's going on here. But this is important stuff. You'll need to know this. All right, then we're going to go on to fetal station. So fetal station is the relationship of the presenting part to the ischial spines of the pelvis. So when the widest diameter of the presenting part is at the ischial spines, this is referred to as zero station. I know this doesn't make a lot of sense to you until I show you the next picture. But you need to have the definitions before we go to the picture. So any position above the level of the ischial spines is referred to as negative station. And any position below the level of the spines is a positive station. So +4 to +5 station is crowning and ready for delivery. The fetal head is seen at the vaginal opening. Okay, because they're further down, 4 below the level of the ischial spines there. So hopefully this explains it a little bit better. This fetal head up here is not even fully engaged. So engagement is when the fetal head is down in this pelvis. Just engaged, sitting nice and tight right here in the pelvis. This would be engaged. Now this baby's head is not really even engaged. If you're engaged, you're probably close to a zero station, fetal station. This baby's still up pretty high to -3. We've got -2, -1, +1, +2, +3 station. Now you can see down here, you're +3. You're getting pretty close here. You're at the cervical os there. All right, and here's another picture for you. So zero station is at the ischial spines here. You're going +1, +2, +3. So +4, +5 is, like I said, we're seeing the baby coming right this second. All right, then we've got powers. This was the third of the 4 P's for labor. Powers, or the primary force of labor, comes from involuntary muscle contractions of the uterus. So the primary force of labor is from involuntary muscle contractions of the uterus. Labor contractions dilate and efface the cervix during the first stage of labor. And then you have your secondary force of labor, which comes from voluntary muscle contractions of the abdomen. So this is the maternal pushing correlated with the labor contractions delivering the fetus. So that's why you'll see on TV shows or whatever, where they tell the mom to wait and rest and don't push until you feel the contraction, because we want things to be as to go as quickly and smoothly as possible. So we're going to wait until we've already got the uterine contractions, that involuntary muscular contraction from the uterus, and then we will have her push, so she's got that voluntary muscle from the abdomen to correlate and deliver the fetus. All right, so uterine contractions are composed of 3 phases. Be sure you understand this, okay? So increment, acme, and decrement. Your increment is your building of the contraction. It is the longest phase. Contraction starts to gain strength. Your acme is going to be at your peak of your contraction. The contraction has reached its strongest point. And then your decrement, obviously, relaxation of the contraction. The contraction of the uterus eases and relaxes to a resting baseline. Okay? So here's a good picture for you. Your increment, you're moving up to your acme, which is your highest point of the contraction, and then down on your decrement. Okay? Now this is also telling you how you're going to measure contractions, which we're going to talk about in a few minutes. But this shows you duration and frequency for measuring contractions. All right, contractions start at the top of the uterus, or the fundus. I know we've talked a lot about fundus, fundal height, fundal measurements. So fundus, remember, is the top of the uterus. So contractions actually start at the top of the uterus, at the fundus, and spread down throughout the uterus, pushing the fetus downward, which in turn puts pressure on the cervix to thin and efface, and thin or efface, that's what effacement means, thinning out, and to dilate or open the cervix. All right, so the uterus between contractions, you can see this is your resting uterus, and this is your uterus during contractions. Tight, clamp down, pushing the baby with each one. And this is mom. Resting at contraction, you know, when the contraction is not there, when she's in a resting phase, and when she's in a contraction phase, it's moved up, it's balled up, the hard, firm, where the uterus is pushing, doing its contracting. All right. Documentation of contractions. There's 3 descriptors: frequency, duration, and intensity. So I've talked about a few of them. I showed you on that last slide. You can go back and refer to that slide. Will probably help a little bit. But frequency is how often they occur. So frequency is measured by counting from the beginning of one contraction to the beginning of the next contraction. And that's recorded in minutes. But that's important to understand that definition of frequency. How frequent are the contractions? And then we're going to have duration. So duration is the time frame from the duration is how long does a contraction last. We're going to measure that from the beginning of the contraction to the end of that same contraction. And that's measured and recorded in seconds. And then we've got intensity. So this is the strength of a contraction. All right, intensity is determined by palpating the fundus at the peak of a contraction. So that's actually manually touching the fundus to see what we're feeling. It's documented usually as mild, moderate, or strong. Mild contractions would be feeling the tip of your nose. It's not too firm. Moderate, it's going to be like your chin. It's still a little bit soft, but getting firm. And a strong contraction is like your forehead. I mean, it is like hard as a rock. That is a strong contraction. All right, can also be measured accurately by an intrauterine pressure catheter, which is not always used as it is an invasive procedure. I think we talked just briefly about this before, but this is when they call internal fetal monitoring, and they'll put an internal catheter in there to actually measure these contractions with this intrauterine pressure catheter, but it is not used routinely. All right, now with the contractions, that strong contraction, we also have periods of relaxations, which is that resting time between contractions. And it's very important to have this resting time, because what happens during a contraction is that there's decreased blood flow through the uterine arteries, therefore decreasing the oxygen flow to the fetus. Okay, so with a contraction, the baby's going to have some decreased oxygen. This is what they will call, if the baby's baby's heart rate may be dropping significantly with contractions. This may be called, fetal intolerance to labor. This baby is not handling all these contractions, and there could be several different reasons, which I'm sure we'll get into later on this. But in general, you're going to have this decreased oxygen to the baby because we've got decreased blood flow to the placenta, to the fetus during the actual time of contraction. So we have to have that relaxation time to be able to allow the vessels to fill back up with oxygen-rich blood for the uterus and placenta. Also facilitates rest for the mom so she doesn't become overtired, and gives her some time to prepare herself to push better with the next contraction. All right, the fourth P for the 4 P's of labor was psyche. This is your psychological state of the laboring woman. So labor process is enhanced if the woman feels confident in her abilities to cope and if she finds ways to work through the contraction. Obviously, if she's fearful, if she's super tense, if she fights against this pain and contractions, we're going to delay the process of labor. All right, mechanisms for spontaneous vaginal delivery. In order for the vaginal birth to occur, the infant must pass through the birth canal or the passageway. Now, the baby doesn't just come down the passageway. It makes multiple turns, believe it or not. And these different turns and movements are referred to as the cardinal movements of delivery. There are 6 cardinal movements. You need to be sure you understand these and know them. All right. Engagement and descent is the first one. Flexion, internal rotation, extension, external rotation, and expulsion. So these mechanisms can overlap or they can occur simultaneously, but they all will happen during fetal movement during delivery. They will all happen. I suggest making note cards because we're going to break them all down here. I would try making note cards of these. This is the order that they go in, and you'll understand that as we go through them, but I would try making note cards of these so that you can kind of get a better feel for it. And I'll show you some pictures as well. All right, so the first one was engagement and descent. This is the initial movement of the fetal head into the pelvic inlet. So I talked about that a little bit earlier when we had the picture for station. Engagement is when the baby's head will actually be fully, engaged in the pelvic cavity there. There's nothing around. You can't move anything between the baby's head and the pelvis. Okay, it's fully engaged right there. Then you've got flexion. This is the fetal attitude, presenting the smallest part of the fetal head to the dimensions of the maternal pelvis. So the fetal head is chin to chest. As the head descends during labor, the fetus often assumes a flexed position as the head encounters resistance from the muscles of the pelvic floor. Okay, then we move from this flexion into this internal rotation. So the fetal head rotates from a transverse position to an anterior position. Transverse is sideways, anterior is front. So in early labor, the fetus's head presents to the maternal pelvis in a transverse position because the pelvis is widest from side to side. Then during active labor, the fetal head will rotate to the anterior position, which is most favorable for delivery. Now, if rotation does not occur, the labor is prolonged because the widest diameter of the fetal head is presenting, making it tougher to fit. If the fetal head rotates posterior instead of anterior, labor may be prolonged as the infant has to rotate further to the anterior position prior to birth. Okay, after internal rotation, we've got extension. So this is when the fetus reaches the pubic arch. It has to extend its head to pass under the pubic arch and symphysis pubis. External rotation, which is birth of the head. The shoulders then have to line up so you'll see it better in these pictures. They extend and then they kind of line back up with the shoulders. And then we've got expulsion or birth, which occurs after the delivery of both shoulders. So those are the 6 cardinal movements of delivery. So again, be sure that you know them, understand the concepts, what's happening to the baby during these different phases. Please, please, please ask me any questions, send me an email, talk to me in class, so I know that you all are getting this. I want you to be sure you understand it. So number 1 picture here, this head is floating before engagement. See, it's not engaged, it's kind of floating around up here. Then we've got engagement. See, fetal head is down. We've got this nice tight engagement here in the pelvis. We've got flexion and we've got descent. We're coming down. We've got further descent and the internal rotation happening. And now we've got complete rotation and beginning extension down here, number 4. Got up here, number 5. We've got to have this complete extension to get past that pubic arch and the symphysis pubis. And then we've got restitution or external rotation. So you see how the baby is coming out, face down, and then we have to turn it back to its side. So we've got the external rotation. All right, we deliver the anterior shoulder first, then deliver the posterior shoulder, and deliver the baby. Now, babies can actually get stuck in these Usually anterior shoulder delivers fine, sometimes posterior shoulders difficult to deliver, and that's something called shoulder dystocia that we'll probably talk about a little bit later. All right, now there are 4 stages of labor. The first stage has a couple of different sections to it though, of course. So your first stage is dilatation and effacement basically, and it's categorized into early labor, active labor, and transition, or what you guys need to know for nursing medical terms is latent phase, active phase, and transition phase. So again, all of these stages of labor are things that are really kind of confusing and things that you guys are just going to have to know. So I highly recommend making note cards of all of these, flashcards, so that you can go refer back to them frequently and easily, describing what each stage is about, when it begins, when it ends, what's happening during this phase, so that you understand what's going on. Your second stage is birth. The third stage of labor is delivery of the placenta, and the fourth stage of labor is recovery. So first stage of labor, dilatation and effacement, begins with the onset of true labor contractions and ends with full dilatation of 10 centimeters. So the first stage generally lasts 8 to 20 hours for primates. These are for your first time moms, and approximately 5 to 14 hours for multips. Okay, sometimes a whole lot faster for both of those, sometimes a whole lot longer. All right, the first stage of labor is subdivided to these 3 phases. So the first one, remember, was latent phase. If you remember, latent means not active. So this is your latent phase. This is dilatation from 0 to 4 centimeters, contractions about every 10 to 15 minutes. It could be a little closer. But as labor progresses, the contractions usually become just a little stronger and closer together. Then we move into our active phase of labor. This is when we're dilating between 4 and 7 centimeters, contractions coming quicker every 2 to 5 minutes, and lasting 45 to 60 seconds, and they're moderate to strong. So remember, moderate was chin and strong was forehead. And the mom has increasing discomfort. For primates, they usually dilate 1.2 centimeters per hour, and multips can dilate 1.5 centimeters per hour during the active phase. Then we move on to your transition phase. During transition, you're dilating 8 to 10. 10 is fully dilated, so we're dilating 8 to 10. Frequency of contractions is 2 to 3 minutes. Duration is 60 to 90 seconds, so much longer duration of contractions. Intensity is strong. That's that forehead strong contractions. And this phase is characterized as the most difficult part of labor. The woman has a strong urge to push as the fetus descends. However, it is very, very important that the woman not push until the cervix is completely dilated. If we don't have the cervix completely effaced and thinned and all the way dilated to 10, we can cause a lot of complications. Some of it being that she can push for hours and hours and not be able to deliver the baby because she's not fully dilated. We can cause swelling to the cervix. We can cause lacerations, actually lacerations to the cervix, which can lead to hemorrhage. So it's really important to talk to the mom, work with the mom, whatever she needs to not push. Usually it's a lot of breathing techniques to not push until she's fully dilated. All right, so all that was first stage. Now we're in second stage of labor, which was birth. This is characterized by maternal pushing. Starts at 10 centimeters dilation, ends with the birth of the infant. Now, oftentimes the woman feels as if she needs to have a bowel movement, and this is actually a very common concern for women. They're like, what happens if I have a bowel movement when I have a baby? And I say, you wouldn't be the first one that ever had a bowel movement when they had a baby. I mean, it happens. We expect that may happen. We know it. It's not a big deal. We're not going to make a big deal about it. It is what it is. However, that is like one of the biggest things. That was always one of my biggest fears when I took care of patients who were still pregnant and were kind of iffy. I mean, they were already dilated some, but they weren't there for labor. We were trying to stop labor. And then if they were feeling kind of funny, they weren't feeling good, they were concerned that maybe they were contracting, and then they tell me they have to have a bowel movement. They are not getting out of that bed to go have a bowel movement. First thing I need to do is check and see where they are in this process of labor. How far have they dilated any? How far are they dilated? What's going on here? Otherwise, we may get the mom up to go to the bathroom, to go have a bowel movement, and she may push out a baby in the toilet. And that's happened before. oftentimes if they need to do anything, if they, she demands she has to have bowel movement, we'll put them on a bedpan. We just won't let them get up and go to the bathroom. All right, so the average length of this stage of labor for primips is 1 to 2 hours, and for multips it can be as little as a few pushes, up to an hour or so. All right, the fetus continues to descend and rotate, and pushing is characterized by steady, slow downward progression of the infant. Now, third stage of labor is delivery of the placenta. So this begins when the baby is delivered. Okay, ends with the delivery of the placenta. Duration is 5 to 30 minutes. Signs of placental separation are a gush of blood, lengthening of the umbilical cord, and globular shape of the fundus. All right, we will also give oxytocin given to help keep the uterus firm and control maternal blood loss. That's kind of a normal standard thing we do, is hang up 1 liter of Pitocin. If the mom has had a lot of bleeding, we'll maybe do 2 bags of Pitocin. And we may have to give her some other medications, but Pitocin is oxytocin. But that's kind of just a normal standard of care. All right, the fourth stage of labor is recovery. So it's obviously going to begin after delivery of the placenta. It's going to last 1 to 4 hours. The woman is observed frequently for signs of hemorrhage and other complications. So we're checking vital signs frequently. Fundal checks, because we're checking where's the fundus, making sure it has gone down, making sure that it's firm and not real boggy and squishy, like that it's firm and contracting. And we're checking lochia to see how much bleeding the mom is having. Women are usually very tired and hungry, and the body is going through tremendous changes after labor and delivery. All right, so the work of labor, the maternal responses to the stages of labor, the work of labor puts a demand on the woman's coping mechanisms. So responses vary with different stages of labor. Your early labor, they're very talkative, excited, anxious. They're ready to go. They get into active labor. They're usually a little more introverted. They use that energy to focus on their contractions. We get into transition, and most women have difficulty maintaining a positive coping mechanisms during this phase of labor and feel really out of control. When we start pushing, we get this sense of relief, better coping skills. They feel more in control of the situation. Now, if a woman is inadequately prepared for labor and loses control during labor, she will start crying, screaming, thrashing, and believe me, we've had a lot of these. The response slows labor progression because they start tensing up all their muscles, and we're not letting the body do what it needs to do. Okay, we're working against, these tense muscles are going to work against your cervical dilatation and fetal descent. And I will need to check on those page numbers for you. I will put an announcement on Blackboard about page numbers. I'm not sure if that's the right page numbers, but we're also going to discuss a lot of other changes that as what we're going to need to care for the woman next week. So that'll be March 7th. All right, so be sure you get back to me if you have any questions or concerns or anything about this lesson. I'll try to do a quick little recap on the 7th also.